Hello from wherever you are. Thank you for tuning in and listening to this lecture. So today we're talking about skin, hair, and nails assessment. And here are our learning objectives for today in this lecture and our agenda. So we're talking about the functions and our health assessment of skin, hair, and nails. So let's start with a little bit of anatomy. So the skin has three main layers, each with a specific role in protection. So we have the epidermis, which is the outer layer, and it acts as our primary barrier against infection, water loss, and injury. It's made of stratified epithelial cells and contains melanocytes. It's important for pigmentation and UV protection. There are no blood vessels in this layer, so superficial injuries don't make us bleed. We have the dermis, which is our middle layer. This provides strength, elasticity, and support. It does contain blood vessels, nerves, hair follicles, and glands, so it's responsible for sensation, pain, temperature, and touch. And then we have our subcutaneous tissue, or our hypodermis. This is made mostly of fat or adipose and connective tissue. It's here for insulation, energy, storage, and cushioning. It anchors our skin to the underlying structures. And this is common site for subcutaneous injections. So when we're assessing the skin, I want you to think which layer is being affected. That really helps you determine the severity, risk, and the healing potential. Hair is found almost everywhere on our body except for our palms and soles of our feet. And distribution changes of hair can really signal hormonal or endocrine issues. Each hair has a root, which is embedded in the dermis, a shaft that extends above the skin, and a hair condition can reflect nutrition, circulation, and overall health. We have our hair growth cycle, and this is important for hair loss. So we have our anagen, or our growth phase, which lasts 2 to 6 years. A majority of hair is actively growing. So a shortened phase can mean hair thinning. Catagen, or our transition phase, this lasts 2 to 3 weeks, where we have hair follicle shrinkage. Then we have our telogen, or resting phase, which lasts 2 to 3 months, where hair eventually sheds. And if our patient is having stress or illness, more hairs enter this telogen phase of shedding. Functions of the hair: protection. So our eyelashes and nostril hair really filter airborne debris. And we also have thermoregulation, which helps with heat retention. Nails are made of hard keratin and are normally smooth, firm, and slightly curved. Growth starts at the nail matrix, or under the cuticle. So damage here affects future nail growth. Functions of the nails: these help with fine motor tasks like grasping small objects. They provide protection to our fingertips and toes, and they enhance sensation by providing counter pressure. They can also be used for scratching. Nail growth: nails grow continuously throughout our lives, and fingernails grow faster than toenails, so toenail issues would take longer to resolve. There are two main types of skin glands. We have sebaceous glands, and then we have sweat glands. So sebaceous glands are located with hair follicles, and they secrete sebum, or oil, and that helps lubricate skin and hair and helps maintain skin moisture and barrier function. So overactivity, we might see acne. Underactivity, we might see did I say dract? I meant dry, cracked skin. And then our sweat glands, these are found over most of the body surface. They are important for thermoregulation and also fluid balance. And then we have types of sweat glands, eccrine glands. These are found everywhere on the body. They produce watery sweat. Their primary role is cooling the body, so in fever or heat exposure. Apocrine glands, they're located in our axilla, groin, areola, and these produce thicker, oily sweat. They're activated at puberty. We see with our apocrine glands that when bacteria breaks down in these areas, we get body odor. So the skin's most important role is going to be protection, and it acts as a barrier against bacteria, toxins, and injury. We have our stratum corneum, our outermost layer of the epidermis. This is a primary protective layer. It's made of dead, tightly packed cells and lipids. It prevents water loss and dehydration, and it blocks environmental threats. So the skin plays a very important role in maintaining fluid and electrolyte balance. Subcutaneous tissue, this helps store moisture and fluids. It provides a reserve that supports overall hydration. And then prevention of fluid and electrolyte loss. So intact skin really prevents excessive fluid loss and electrolyte imbalances. So with any damage here, we have increased risk for infection and also fluid loss. The role of lipids. Lipids create an impermeable seal, and this helps maintain skin hydration and integrity as well. So when we see dry, cracked skin, we have a break in the barrier and we have an infection risk. So this is really important, not only in healthy young adults, but in the elderly and also dehydrated patients. And then we have the basal layer, which is responsible for new skin cell production. It supports healing and regeneration. So injury here affects our ability to heal and can be seen in deeper wounds or burns. So any break in the skin is really a portal of entry for infection, and in high-risk situations like pressure injuries, burns, IV sites or surgical wounds, or severely dry or cracked skin, we need to be aware of that. So the skin is also a major sensory organ. It contains nerve endings that detect environmental changes. So we have types of sensation with temperature, hot and cold, pain, touch, and pressure. And these sensations are really critical for our protective reflexes, like pulling away from heat. We have distribution of nerve endings, so we have more concentration of nerve endings in our face, hands, and feet. These areas are more sensitive. They're also more noticeable when sensation is impaired. And the skin plays a major role in maintaining body temperature, like we talked about. So heat loss mechanisms like radiation, where heat transfers to the surrounding environment without any direct contact. So the body losing heat to cooler air. Conduction, where heat transfers through direct contact, like lying on a cold surface. Or convection, where heat loss is through movement of air or fluid, where we have wind or a fan carrying heat away from our bodies. Evaporation, where sweat evaporates from our skin. This is a key cooling mechanism, especially during fever or exercise. So any ineffectiveness here, like high humidity, can lead to fluid loss and dehydration risk. So the role of blood flow, we have this is controlled by the sympathetic nervous system. Vasodilation, we have increased blood flow to the skin, which can result in heat loss. Or vasoconstriction, where we have decreased blood flow to the skin, where we have heat conservation. And that is controlled by our sympathetic nervous system. So skin findings really tell us a lot about temperature status. When we see warm, flushed skin, note that that is vasodilation. and cool, pale skin can indicate vasoconstriction, and diaphoresis, where we have active cooling or a stress response occurring. The skin also plays a role in vitamin D synthesis when exposed to ultraviolet light. So vitamin D, essential for calcium absorption and bone health. So a deficiency in this can lead to osteoporosis in adults and rickets in children. About 15 to 30 minutes of direct sunlight daily can really help support vitamin D production, but this can vary based on skin tone, geographic location, and season. Sunscreen can decrease that vitamin D synthesis, but there's really a balance that's needed between that sun protection and that vitamin D absorption. Diet and supplements. Many patients require dietary intake or supplements of vitamin D, especially older adults or patients with limited sun exposure, like here in the north, and then darker skin tones. So even though the skin produces vitamin D, many patients are still deficient, and nursing considerations with this is we want to assess risk factors for any deficiency, monitor for bone weakness or fractures, and then education on diet and safe sun exposure. So the skin is not just a barrier, it's an active immune organ. It provides innate and adaptive immunity. So innate immunity includes the stratum corneum with that physical barrier we talked about. Also a chemical environment, acidic pH and antimicrobial substances are located on the skin. We also have that inflammatory response that occurs where we see redness, warmth, and swelling when we have acute trauma to the skin. And this is the body's immediate response to any injury or infection. And then we have adaptive immunity as well. This involves specialized immune cells, especially the Langerhans cells, and these act as antigen-presenting cells. The role of those cells is to detect foreign substances like antigens and transport them to lymph nodes, which activate a more targeted immune response. So our skin does a lot for us. There's many functions, so keep that in the back of your mind. Now we're going to go into the actual health assessment of skin, hair, and nails. So a thorough skin health history really is going to help us identify risk factors, causes, and patterns before we even assess the skin. So key questions to ask: do they use any products on hair, skin, or hygiene products? Because new products could possibly create contact dermatitis if maybe they're coming in with that. We want to get personal and family history of any skin conditions like eczema, psoriasis, or acne. Skin cancer history is going to be also important for risk stratification. Allergies to foods, medications, or chemicals. This can present as rashes, hives, or severe reactions. And then onset and symptoms, we want to ask about onset, location, duration of symptoms, pain, itching, rash, or discomfort. We want to reason between if this is an acute versus chronic, which is going to help narrow down what's actually going on with the patient. Any exposure history, so specific products are used, like soap, shampoos, or cosmetics, will tell us about exposure. Any new medications or herbal supplements. Many rashes are medication related. And then skin cancer risk factors, so sun exposure history, if they've been utilizing any protective behaviors like clothing or shade or sunscreen against skin cancer, because early identification and prevention is really going to be important. Most skin issues can be traced back to exposures, history, or patterns. So it's important that we ask and tie these in together before we even look at the skin. because our history is going to guide us towards a likely cause and our priority concerns with that patient. So a skin assessment should really be comprehensive. It's going to include the entire skin surface, plus mucous membranes, scalp, hair, and nails. The skin often reflects systemic disease, not just any local problems. So our techniques that we're going to use, inspection, we're going to look carefully at the color, lesions, and overall appearance of the skin. We're going to palpate to assess temperature, moisture, texture, and mobility. We're going to use a well-lit, warm room because we want to prevent any patient discomfort and improve accuracy of our assessment. A pen light can help visualize subtle lesions or any color changes. We're going to position our patient. The patient should disrobe as appropriate with proper draping. We're going to ensure full assessment while maintaining their dignity and privacy. Gloves, we want to put those on, standard precautions for safety and infection control. And we really want to observe color like pallor, cyanosis, jaundice, because again, these can indicate systemic issues. We're going to evaluate temperature and moisture. Are they warm versus dry and cool or clammy? We're thinking about perfusion or the endocrine system. Texture, is the texture of their skin smooth versus rough? Could indicate hydration status or aging or even disease. Lesions, we're noting the size, shape, color, and location of those lesions, if there are any. Vascularity, so bruising or spider veins could mean possible vascular or liver issues involved. Mobility, skin should be mobile over the underlying tissue. Hair and nails, we're assessing for distribution, texture, and abnormalities there. Skin turgor, edema, and elasticity. Turgor to assess hydration status. So delayed recoil of the skin when we pinch it could indicate dehydration. We're also looking at edema, which can indicate fluid imbalance. Elasticity, we know that this decreases with aging, and it can also decrease with dehydration, so it can tell us a lot about their hydration status. But your hands and your eyes are going to be your best tool, and you're constantly asking, what does this tell me about perfusion, hydration, and their overall health? So a good skin assessment is never just about the skin. It's really a window into the patient's circulation, hydration, and systemic health. Assessing skin color, this is influenced by genetics and that melanin production. So it exists on a spectrum from light to dark. So darker skin, we have more active melanin production. So we're always assessing color in relation to the patient's baseline. In darker skin tones, we want to assess for any color changes in the mucous membranes, the palms and soles of feet, conjunctiva, so the eyes, and the nail beds. Color changes like hypopigmentation or decreased melanin can be seen in fungal infections, eczema, or vitiligo. And then on the opposite of hyperpigmentation, where we have increased melanin, this can be caused by sun exposure, aging, and post-inflammatory changes. So there are normal variations in the skin where we see pigmented creases in the palms, soles of the feet, longitudinal nail streaks, scleral spots, linea nigra, which is a dark line on the abdomen in pregnancy. So these are expected findings, especially in darker skin tones. So we want to know what's normal versus abnormal. And color changes can indicate systemic problems, again, not just underlying skin issues. So things like pallor, this can indicate anemia or poor perfusion. Cyanosis can indicate hypoxia. Jaundice can indicate liver dysfunction, and erythema or inflammation and infection. So when assessing our skin, we always want to ask, is this normal for this patient, or is this a change? Because any subtle color changes can be early signs of a serious condition. So skin assessment, it must be adapted for all skin tones. We're not going to just rely on typical color descriptions like redness or blueness. We want to focus on tone changes, not color labels. So with cyanosis in lighter skin, this can appear bluish, and in darker skin, it can appear gray or ashen or even dull. So the best areas to assess cyanosis would be in the lips, nail beds, and oral mucosa. And this can, again, indicate hypoxia, which we need to urgently assess and intervene. Pallor is really harder to see in dark skin colors. So again, we're really assessing the conjunctiva, the mucous membranes, palms, and nail beds. Erythema, this may not appear red in darker skin. So instead, we want to assess for warmth, swelling, and tenderness. It can also be an early sign of infection, inflammation, or pressure injury. So if you're going to rely only on color, you're going to miss some important findings. So we always want to assess temperature, texture, and our patient's symptoms. So cyanosis can mean decreased oxygenation in the blood, and it can indicate impaired circulation. This is really a late and serious finding. Some common causes can include respiratory failure, cardiac issues, and shock. Again, we want to note the differences in appearance from lighter skin, where we're going to see bluish discoloration of the lips, nail beds, and fingertips, versus darker skin, where it may appear gray, ashen, or dull. Again, we're focusing on those areas with less pigmentation, like the lips, oral mucosa, and nail beds, or conjunctiva, even the earlobes and cheekbones. And we want to see about associated clinical signs. Often they'll have cool, clammy skin, rapid, shallow respirations, rapid, thready pulse with cyanosis. So again, these findings are going to suggest poor perfusion and oxygen delivery, which is an emergency. Then we have ecchymosis, or bleeding under the skin, also known as bruising. So this results in color changes over time. So we'll see that bruise go from purple to blue, green to yellow, and then brown. This reflects the breakdown of blood products. Common causes, this most often due to trauma or injury to the skin, can also be related to anticoagulant use, bleeding disorders, or fragile skin in older adults. Again, assessment in different skin tones. So lighter skin, we see color changes that are more visibly obvious. And in darker skin, it may appear darker, dull, or subtle discoloration. So we may need to, again, rely more on palpation with tenderness, swelling, erythema. Older adults, they're more prone to thinner skin and decreased collagen and fragile blood vessels. So bruising may occur with very minimal or even no known trauma. Our assessment considerations, we want to evaluate the size, location, pattern, and stage of healing. Some red flags would be unexplained bruising, bruises in unusual areas like the torso, inner arms, or face. In different stages of healing, that may indicate bleeding disorders, medication effects, or possible abuse. Erythema, which is increased blood flow to the skin. This is caused by capillary dilation, typically associated with inflammation. Some common causes include infection or inflammation, fever, blushing or an emotional response, and then alcohol intake. This is often an early sign of a problem, especially infection. The appearance in different skin tones. So we see with lighter skin, this appears red, and darker, it may appear purple, gray, or darker than surrounding skin. So The key point here is it may be missed if we're only looking for redness. So don't rely on the color alone. We need to palpate the area, assess for warmth, swelling, firmness or hardness, and then tenderness. So, like I said, erythema is often the first sign of an infection or a pressure injury. So high-risk areas we're looking over bony prominences, under medical devices, and IV sites. Jaundice is yellowing of the skin and tissues. It's caused by elevated bilirubin levels. It indicates a problem with the liver function, bile flow, or red blood cell breakdown. So where to assess first? We often see this in the sclera of the eyes and the mucous membranes. And these areas are more reliable than the skin alone, especially across different skin tones. So best areas to assess would be the sclera of the eyes, the hard palate, and the oral mucosa. You want to think about with jaundice underlying causes like liver disease, hepatitis or cirrhosis, biliary obstruction, so gallstones, or hemolysis, so red blood cell breakdown. We may also see dark urine, pale stools, and pruritus or itching associated with jaundice. So this helps us determine the source of bilirubin that is the problem here. Assessing rash, we want to start with patient inquiry. So when we're assessing rash, we always begin with our subjective data. Ask about the itching. This can point towards allergic or inflammatory causes. We want to clarify the onset and progression. When did it start? Has it spread? Has it changed? We want to ask about any recent exposures with new soaps, lotions, detergents, medications, illness, or sick contacts. And then we're going to shift into our objective assessment. So we're inspecting the rash and then palpating. Stretching the skin really helps to determine if redness is blanchable, so vascular, or non-blanchable, where we have possible bleeding under the skin. We want to use good lighting or a pen light to better visualize any color variations, borders, and distribution of the rash. Light palpation is going to help us assess texture. Is this smooth, rough, or scaly? And then elevation, is this flat versus raised lesions? Temperature, because warmth may indicate infection or inflammation. Additional observations, skin findings are often systemic clues, so we're going to inspect mucous membranes and ears. Some conditions like viral conditions show up here too, so we want to assess for fever, which can suggest infectious process, and palpate the lymph nodes. These can be enlarged and can indicate a systemic infection or an immune response. Your book highlights the importance of really looking beyond the rash itself to identify any systemic involvement. We don't want to miss that. Characteristics of skin lesions. So when we talk about skin lesions, we're really focusing on describing what we see in a systemic way. So lesions can vary widely in size, shape, color, and cause. So using consistent terminology is going to be key. So we want to always think, what does it look like? Where is it? And how is it distributed? We have primary versus secondary lesions. One of the first things we do is classify these as primary or secondary. So primary lesions, these are the initial lesions. They're directly reflective of an underlying disease process. Examples you might think of, macules, which are flat, papules, which are raised, and vesicles, which are fluid-filled. And these are important because they give us clues to the original condition. And then we have secondary lesions. These occur after the primary lesion changes. They're often due to scratching, infection, or healing processes. Examples might include crusts, scales, and ulcers. So here we're not seeing the original problem, we're seeing the result of what actually happened to it. And then further categorization. After identifying whether this is a primary versus a secondary lesion, we go deeper and we categorize these based on the appearance, type, So whether this is has color, borders, or symmetry, and this is flat, raised, and filled with fluid. And these frameworks or tables are in your book, table 56-2. I encourage you to take a look at. So assessing vascularity and hydration. So when assessing vascularity, we're really looking at what the skin is telling us about circulation. So we're assessing location and distribution. Is it localized or widespread? We're looking at color. Is this red, purple, blue? It can indicate different processes of the healing stages. Size can help us differentiate between benign versus concerning findings. And then checking for pulsations, if applicable. This may indicate vascular involvement. Common findings to really recognize petechiae. These are tiny, pinpoint, non-blanchable spots which can indicate possible bleeding under the skin. Ecchymosis, which is larger bruising. Telangiectasias, which are small dilated blood vessels. They're often benign but can be systemic. Angiomas, which are benign vascular lesions. We want to recognize these patterns because they can signal underlying conditions like clotting disorders or liver disease. And then we're shifting to hydration. So we're assessing the skin moisture. Is it dry versus diaphoretic? Temperature, cool, warm, or hot? Again, can indicate perfusion or infection. And then texture, smooth, rough, thin. We're looking at skin turgor. This is, again, a quick way to assess hydration status. We're going to gently pinch the skin, often on the forearm or even the clavicle area. So normal would indicate that the skin returns quickly back to its original spot when you're pinching it. Dehydration, we see tenting or slow return. But turgor is less reliable in older adults, so we use additional clues in that situation. Edema assessment. This gives us clues about fluid balance and possible cardiac, renal, or vascular issues. So we're assessing the location of dependent areas like the ankles, if this is pitting or non-pitting edema. For edema, we want to press firmly and we want to note the depth of the pit, how long it takes to rebound back. And this gives us a grade of edema and we're able to track changes over time. Nail inspection. So nails can actually tell us a lot about the patient's overall health, not just local issues. So when we're assessing, we want to focus on the configuration, so the shape and contour of the nail, the color. Is this a pink, pale, cyanotic, or yellow? Consistency, so thickness or brittleness. Nail changes can reflect both local problems like infection, but also systemic conditions. So always ask yourself, does this look normal for this patient? We're comparing bilaterally and we're considering the patient's age, circulation, and chronic conditions as well. Common findings, view lines. These are transverse grooves across the nail. This is often occurring after severe illness, stress, or trauma. It can reflect a temporary interruption in nail growth. Parenchyma. This is inflammation or infection around the nail. We're looking for redness, swelling, tenderness. It's often related to bacteria or frequent moisture exposure. Pitted nails, these are small depressions in the nail surface, commonly associated with psoriasis. Spoon-shaped nails, nails that curve upward like a spoon. This is associated with iron deficiency anemia, so we want to think about nutritional deficiency. Clubbing, this is a really important one to recognize, where the nail angle increases and fingertips become bulbous. This is associated with chronic hypoxia, and it's often seen in lung disease like COPD or cardiac conditions. This image is a great summary of what normal versus abnormal nails look like. So this is exactly what you want to picture during your assessment of the nails. We have a normal nail at the top, where the angle is about 160 degrees and the nail sits naturally on the nail bed. This is our baseline, so we're always starting by knowing what normal looks like and then comparing to the various abnormal shaped nails. Hair assessment techniques. So hair assessment is pretty straightforward, but again, it's going to give us important clues about the patient's overall health. We want to start with inspection and then move towards palpation. We're looking at color, texture, distribution. When we're inspecting, we're focusing on areas of the scalp, assessing evenness of hair distribution, any patchy hair loss, any conditions of the scalp underneath. Abnormal findings, so key things to assess like lesions, sores, or bumps. Itching could indicate irritation, lice, or dermatitis. Inflammation or redness like scaling or flaking, you want to think dandruff or psoriasis. And then infestation with lice or nits. So these findings can point to infection, dermatologic conditions, or hygiene concerns. And then we're looking at the hair color and texture, and this will naturally vary from white to black, so focus more on changes rather than baseline color. Texture can range from fine to coarse, silky to brittle, oily to dry. And changes in hair texture are where clinical judgment comes in because it can indicate overuse of products or heat damage, nutritional deficiencies, or endocrine disorders like thyroid issues. So like dry, brittle hair might make you think about hypothyroidism. And then body hair distribution. So when we're assessing hair distribution, we're looking at what's normal versus what might signal something systemic. So typically fine hair covers most of the body. Coarse hair is found in areas like the axilla and pubic regions. So always considering age, sex, genetics, and culture variations before labeling something abnormal. Pubic hair patterns. There are expected patterns based on biological sex. So males have diamond-shaped distribution extending towards the abdomen, and females have like an inverted triangle. So if you see the opposite pattern, this can be a clue to an endocrine imbalance, particularly androgen-related disorders. Alopecia, so hair loss is really important. It can be localized. We want to think about conditions like alopecia or fungal infections, or it can also be generalized, and we want to think about systemic causes. So causes of alopecia, habitual hair pulling, infections, medications, chemotherapy. Also consider hormonal imbalances or even nutritional deficiencies. Male pattern hair loss, this is the most common type of hair loss we'll see, also called androgenic alopecia. This affects over half of males, especially with aging. It's caused by a combination of genetics, aging, and testosterone levels. Typically starts with a receding hairline and thinning at the crown, and it can progress to baldness. This is usually normal and expected finding, but still important to recognize. And then we have female pattern hair loss. So hair loss in females is also very common, but it looks different. So instead of a receding hairline, where thinning usually occurs at the top of the scalp, and the frontal hairline is often preserved. So the pattern is more diffuse rather than patchy or receding. So it's always important to assess for changes from baseline. And with both male and female pattern hair loss, we want to ask, is this expected or is there something else going on? Other changes include hirsutism, which is excessive hair growth in areas where it's not typically expected, especially in females. And this can occur with menopause due to hormonal shifts. But if menopause is ruled out, this is where your clinical judgment kicks in. If hair changes don't match expected patterns, we want to think about endocrine causes, possible hormonal imbalances for females like PCOS or adrenal disorders. Oh, I'm sorry, I skipped the slide with the male and female pattern hair loss pictures, but encourage you to go look at that. It's just exactly what I explained in the slide right before. But now we're getting into more focused, targeted history, specifically about skin lesions. So we want to think of this as really diving deeper after the patient has said, I have a rash or I've noticed a spot. So our first question is, how long has it been there? This is going to help us determine if this is acute versus chronic, sudden versus gradual onset. This is really a key starting point for our clinical reasoning. And then we want to ask, does it come and go, or is it constant? Recurring lesions may suggest chronic conditions like eczema or psoriasis, or even allergic reactions. Seasonal variation, this is a great clue that sometimes we forget, is some skin conditions can worsen with weather changes, like dry winter air or summer allergens. We want to ask about family history, any skin conditions in the family, because many conditions like psoriasis or eczema have a genetic component. And then occupation and hobbies. This can be huge for identifying any exposures, like chemicals, irritants, or outdoor exposures to plants or the sun. So like contact dermatitis or environmental causes. Medications, we're always reviewing medications because some can cause drug reactions or photosensitivity. So new medications can be a big red flag for any new skin findings. And then allergies, we're asking about known allergies, especially any prior skin reactions. It can help us identify triggers and prevent recurrence. And then previous treatments, what has the patient already tried? Did it work? This really tells you about the severity of what's going on and the response to treatment, and then possible diagnostic cues. Factors influencing the condition, ask the patient what makes it better, what makes it worse. We want to think about soaps or lotions, heat and sweating, or even stress. This can help us identify patterns and also triggers. So all these questions are going to help us build a story behind the lesion. And now we're getting into skin lesion terminology, which is really about learning how to accurately describe what we're seeing. So primary lesions, these are going to be the initial lesions, and they're reflective of the underlying disease process itself. So we have a macule, which is flat. You cannot feel it. It's just a change in color, not texture. Examples of this, freckles, petechiae, vitiligo. And your book has great pictures in this chapter. I did not include the pictures in here. I'm just including the descriptions of the differences in the primary and secondary lesions. So if you're a picture person and you like visuals, I encourage you to go look in your book at the pictures, or even just Google it. It's great. So we have a papule. This is a raised lesion. You can actually feel it. It's firm, usually less than 1 centimeter. Examples of this include insect bites, scabies. This is your classic small bump on the skin. A nodule is like a deeper, larger papule. It's firm, it's palpable, it extends deep into the layers of the skin. It's larger than 2 centimeters. Examples of this, warts, or even erythema nodosum. So we want to think bigger and deeper than a papule. Plaque, this is a flat-topped raised lesion. It's usually rough, larger than 2 centimeters. It forms when papules merge together. Some examples of this would be psoriasis. So a quick way to differentiate. So a macule is flat, papule is small and raised, nodule is larger, deeper, and plaque is flat-topped and wide. So we're continuing here with primary lesions. Again, these are the initial skin changes that reflect the disease process. So we have a wheal. A wheal is what you typically see with hives. It's raised, irregular shape, often transient. It comes and goes. Color can vary from red to pale to white. These are caused by localized edema, not fluid-like a blister. So if a patient says it comes and goes quickly, we want to think, is this a wheal? A vesicle. This is a small fluid-filled blister, less than 5 millimeters in size. So examples of this would be herpes simplex or varicella, like chickenpox. These are superficial, and you can often see the clear fluid inside. A bulla is basically a larger vesicle. Example would be it's greater than 5 millimeters. We see this with Bullous pemphigoid. This is the same idea as a vesicle, it's just bigger. A pustule, this looks like a vesicle, but instead of clear fluid, we have it's filled with pus. So examples of this would be acne or impetigo. We want to think infection or inflammation when we see pus. And now we're moving into secondary lesions, and these are not the original problem. They're going to develop after the primary lesion, often from scratching, infection, or the healing process. So we have a scale, which is flaking skin, basically a buildup of dead skin cells. It can be dry or oily, it can be thin or thick. Examples of this: psoriasis, dandruff, or eczema. A crust. This is a dried material on the skin, could be serum, blood, or pus. Examples: impetigo, where we have classic honey-colored crust after the original primary lesion. So think something has oozed and then dried. Erosion. An erosion is a shallow loss of the epidermis. It looks moist, red, but it does not bleed. An example of this would be a ruptured blister. So this is more superficial damage. And then an ulcer. An ulcer is deeper than erosion. It involves loss of the epidermis and dermis. It may bleed and it can scar. This is more serious and it often requires further evaluation. Excoriation. This is caused by scratching. It appears as linear marks, superficial skin loss. Examples of this would be atopic eczema. Fissure. A fissure is a crack in the skin. You often see this in dry skin or fungal infections like tinea pedis. These can be painful and deep. Lichenification. This happens with chronic rubbing or scratching where the skin becomes thickened, rough, with more visible skin lines. Example of this would be chronic eczema. This tells you the problem has been going on for a while. And now we're looking at common benign skin lesions. These are non-cancerous, but still important to recognize. And the key is knowing what's normal or benign versus what needs further evaluation. So skin tags, these are very common. They're soft, fleshy growths that hang off the skin, often found in the neck, axilla, or groin, completely benign. No treatment needed unless the person is irritated by them. Dermatofibroma. This is firm, hyperpigmented nodules. They often feel like they're stuck in the skin, even though they're benign. We want to check these out just to rule out any malignancy. Neurofibroma. These are soft nodules, usually less than 2 centimeters, can be solitary or we have multiple. These are associated with neurofibromatosis. If they are numerous, again, benign. Sebaceous cysts. These are skin-colored nodules that may have a central opening that can become inflamed or infected. They're often confused with abscesses, so we might check these out a little bit further than just like a skin tag, but like checking for infection. Lipoma, this is a fatty tumor under the skin. It feels soft and mobile, usually painless and benign. Ganglion cyst, these are fluid-filled cysts, often near the joints or tendons, commonly in the wrist. Even though I don't know what I was going to say about this, but ganglion cysts, very benign. We can get rid of those by just putting a lot of pressure immediately and quickly onto that. Cherry angioma, these are bright red lesions made up of blood vessels. These are common with aging, totally benign, but can look alarming to patients. Solar lentigo, these are sun-induced dark spots, often called age spots. They're found in sun-exposed areas. But again, important to differentiate between malignant lesions, which we'll talk about soon. And then nevi, these are moles. Again, very common, but we're doing our ABCDE assessment for melanoma risk when it comes to these. Hyperkeratonic lesions, these are thickened skin from chronic friction. Examples of this would be calluses, so it's a protective response of the skin. Keloids, these are overgrowth of scar tissue, which extends beyond the original wound, more common in certain populations and can be cosmetically concerning, but very benign. So our ABCDE of melanoma, this is one of the most important tools you'll use when assessing moles or pigmented lesions, and the goal is to quickly identify potential melanoma or concerning lesions. So we look at A for asymmetry. We want to ask, do both halves look the same? Is it normal, aka symmetrical, or is it concerning where one half does not look or looks different than the other? So if you drew a line through it and it doesn't match, it's a red flag. Border, we look at the edges of the mole or lesion and we see if this is normal, meaning smooth and even borders. What is concerning is more of irregularly shaped, jagged, or blurry edges. C for color, we're assessing the color throughout the lesion. Normal would be one consistent color. Concerning would be multiple colors like brown, black, red, white, blue, and variation is a key warning sign. Diameter, so size matters here. It's concerning if it's greater than 6 millimeters, so about the size of a pencil eraser. But remember, melanoma can still be smaller, so we're not relying on size alone. That's why we're checking our A, B, C, D, and E. And then evolution. This is one of the most important ones. We want to ask, has it changed in size, shape, or color? So any new symptoms like itching or bleeding and any change over time would be the biggest red flag. And we're not diagnosing melanoma. We're just identifying the risk and we're escalating the care as needed. Maybe referring them to dermatology. Now we're looking at the integumentary system changes across the lifespan. This is important because what's normal in one age group may be abnormal in another. So during pregnancy, we have a lot of hormonal changes that stimulate melanocytes, and this can lead to melasma, where we have dark facial patches, striae or stretch marks, and that linea nigra, which is the dark line on the abdomen. These are expected and benign changes. Newborns or infants, so newborn skin can look very different, and that's normal. Common findings, vernix, which is that white creamy coating once they first come into the world. They can also have lanugo, which is fine hair, milia, tiny white bumps, even physiologic jaundice, and many of these resolve on their own. Children and adolescents, in this group, we start to see more infectious and inflammatory conditions like impetigo, eczema, sunburn, and acne. Hormonal changes during adolescence drive a lot of these findings. In adults, we want to think about chronic and environmental exposures, common conditions, fungal infections like tinea or ringworm, psoriasis, cold sores, and contact dermatitis. So lifestyle and occupational exposures play a big role here in adults. And then older adults, where we start to see structural skin changes due to loss of collagen and elastin, which result in decreased skin turgor, thinning, more fragile skin. Common findings, we see that age spots, skin tags, and these patients, these older adults, are at higher risk for skin breakdown and injury. So lastly, in this lecture, we're focusing specifically on normal aging changes in the skin. This is really important because these patients are at higher risk for injury and complications with that thinning epidermis, making it more fragile and easy to injure, dry, flaky skin due to decreased oil production, which can lead to itching, which can increase the risk for skin breakdown, fragility and shear risk. So their skin, since it's much more fragile, any minor friction can cause skin tears. So we want to avoid adhesive tape when possible. We want to use gentle handling of their skin. It's a big safety point in clinical especially. They also have decreased subdermal fat, so loss of fat under the skin. This reduces cushioning and the ability to retain heat, so they get colder easily and are at higher risk for pressure injuries. They also have decreased sensory perception. They may not feel pain or pressure or temperature as well. So this increases their risk for burns, injuries, and pressure ulcers that are more severe. Decreased skin turgor. So this happens with aging, and this is not always a reliable sign of dehydration in older adults. So again, we need to use other indicators when assessing hydration status. UV-related lesions, so over time, sun exposure can lead to age spots and precancerous findings on the skin, so we need to be monitoring for that. And then thick nails. Nails often become thicker and more brittle, which can impact their mobility and self-care. Slow wound healing. It's going to take longer due to decreased circulation and slower cell turnover. So this increases the risk for infection and chronic wounds. So with older adults, your focus shifts to prevention and protection, and you want to ask yourself, how can I prevent skin breakdown in my patient? And how can I protect their fragile skin? So we're just under an hour. I appreciate you listening to the lecture. I can't wait to do some assessments and some activities based on this information. So I will see you in class.